Now, a keynote from Dr. Filip Meheus, the health economist at the International Agency for Research on Cancer, and it's going to be on planning and costing cancer control interventions, a health economics perspective.
So thank you very much for that introduction. Your Royal Highness, Your Excellencies, distinguished colleagues and friends. It's an absolute pleasure to be here with you today, and I would like to thank the organizers as well as the host country for inviting me to speak. So I was asked to talk about planning and costing cancer control interventions. I will do that, more or less. Yeah? I was asked not to mention the word expensive too much. I will also try to do that, primarily because the words cheap or expensive is not how we economists describe an intervention. We rather use words such as not cost-effective or cost-effective, which is not the same, by the way. But joking aside, I must say that the World Cancer Congress, or Leader Summit, has been a truly interesting meeting so far. And it's encouraging to see so many people gathered here today in the same room, not only discussing the importance of universal health coverage and cancer, but also cancer and universal health coverage, but also committed to making sure that people are able to get access to quality healthcare services, irrespective of their social and economic status, and therefore their ability to pay. Of course, being the last presenter today, there may be some overlap with what has been presented, but I think repetition is never a bad thing. I've tried to be practical in my presentation as well, showing you how we as a community, and in particular as UN agencies, how we can contribute to effective cancer control planning, in particular through the promotion of explicit and transparent priority setting processes, showing value for money, efficiency, but also make sure that countries are publicly accountable for any actions that they're actually undertaking. So as a starting point, let us take a quick look again at the global economic impact of cancer. So we know that cancer is the second leading cause of death worldwide. We also know that about 170 million years of healthy life were lost due to death and disability because of cancer. Now, if we look at the economic impact of cancer, unfortunately, our knowledge is much more limited. So there are some figures around, but due to definitions and differences in cost categories that are included in these estimates, they're actually quite wide-ranging. So we know that, for instance, cost of cancer, or total annual economic cost of cancer, is estimated at approximately 1.2 trillion. And so this includes primarily the cost of prevention and treatment, as well as some indirect costs. Other estimates go upwards to 2.5 trillion US dollars when you also include the loss of pain and suffering. Now, these are of course staggering numbers, and then even myself, I sometimes have difficulty to understand what basically a trillion is, because these numbers are so big. But to put this in a little bit of a perspective, for instance, the American Cancer Society showed that the highest economic loss of all of the 15 leading causes of cancer of death, of all the 15 leading causes of death worldwide, were due to cancer. And I will come back later on why I'm mentioning these numbers. Now, we've also heard quite a lot today that cancer causes substantial burden to patients and families. Fortunately, we have an increasing number of studies that have been quantifying the economic impact of cancer at the household level. And I just want to put some of them here on the table so that you understand the magnitude of the burden of cancer to households. So for instance, in India, we know that more than 60% of those seeking cancer care experience out-of-pocket expenditure, which is actually greater than 20% of their household income. In Vietnam, 37% of households are impoverished due to cancer expenditure, and actually 57% of these households pay more than 50% of their household budget. And even in countries such as Thailand, 24% of households still face financial catastrophe despite having a comprehensive universal health coverage scheme. Now, one of the things that we also see consistently within those studies is that low socioeconomic status is generally associated with an increased risk of financial catastrophe, except actually in the lowest income category. And you may wonder why. Well, the reason is very simple, is primarily because the poorest people actually do not go and seek healthcare services because of the anticipated cost. Now, one of my messages as well today is that too frequently we still see the costs of cancer care or the cost of cancer to the healthcare system as something negative and something unaffordable. Now, there's of course no denying that the cost of cancer care is expensive. Here I am using the word. But there is also actually cost to cancer itself. Not doing anything has an impact. So not only in terms of the lives lost, as we've seen today, and the suffering cost to families, but also to society and economy at large. And so the cost of inaction should also be quantified and should also be part of building a case for investing in cancer prevention and control. And so to give you one last example, this is, for instance, a study that was conducted by IARC last year. So in terms of lost productivity, we showed that lost productivity due to premature cancer mortality in the BRICS countries, we showed that the total loss was approximately 46 billion, representing 0.33% of combined GDP within those countries. Now, one of the things that I haven't seen too much today is that, and that's because, of course, a lot of the media attention often goes towards the cost of cancer. We should not forget that investment in cancer prevention and control has yielded substantial benefits over the past decade in high-income and many higher middle-income countries. This is, again, another study conducted by IARC and which was published last month in the Lancet Oncology, and which showed that survival continues to improve across high-income countries. And this is primarily due to policy reforms that have ensured improved pathways to earlier diagnosis and treatment. And so the example that I sometimes use is the one of Denmark, where you see clear and substantial increases in survival, and this primarily resulted from healthcare reforms implemented in 2007 in the field of diagnosis and treatment, in particular reduced waiting times in hospitals and large investments in radiotherapy. And if we look across all OECD countries, we see similar patterns whereby between the period of 1990 and 2015, we've seen a substantial decrease in cancer-related mortality of, on average, 18%. Now, when we look again at building this investment case for cancer, we should not forget as well that the benefits of investing in cancer prevention and control not only saves or prolongs lives, but it also improves workforce participation and the country's economic productivity. We should also mention that it also saves money in terms of reduced healthcare expenditure, in particular through prevention and early detection. So given this significant economic return that we still need to quantify as well, so we need to focus much more also on making a financial argument for investing in cancer control. This is in particular an argument that convinces many other stakeholders, such as the Ministry of Finance, in particular when we want to argue for increased spending on cancer and health in general. Now, there is, of course, no denying that there is a cost to cancer control. And again, if we look at high-income countries, there is ample evidence that the cost of cancer has made the prevailing model of based on treatment unaffordable in most countries. For instance, if we take, for instance, drugs and expenditure on drugs, and I'll take my country, which originally I'm from Belgium, as an example, in the space of 3 years' time, the expenditure on cancer drugs actually doubled from 500 million euros to 1 billion. So we also know that, in particular in high-income countries with the 2008 economic crisis and stagnating growth rates, the current rise in cost of cancer is going to become unaffordable, and no country will have the money to actually fund a wave of investment in innovative medicine and increasing costs. So, of course, in low middle-income countries, the starting point is different in terms of their capacity to implement cancer prevention and control activities, such as infrastructure and human resources. But the challenges in terms of affordability and access to quality cancer services are fundamentally the same. And this is why, this brings me to why I'm actually standing here in front of you today, is that if we want to make cancer prevention and control available, but also affordable, we will have to make choices. And I often use this quote from the Lancet Commission on Affordable Cancer Care, is that where our choices or refusal to make choices will actually affect the lives of millions of people. So of course we're here today to talk about universal health coverage. And so let me start doing that a little bit as well. So coming back to UHC, we often do so by looking at 3 dimensions reflected in the cube here, presented on the slides. And I'm sure you're all very familiar with this cube. So it basically portrays 3 sets of decisions that policymakers need to make: decisions on benefit design, decisions on coverage, as well as decisions on how much patients need to pay for those services at the time of use. So while Robert Yates focused on the financing side this morning, I'll go into a little bit more in detail into the service coverage dimension in low and middle income countries and how we can actually support countries in expanding access to services. So a question we very often get is, so which services should be covered? Of course, in a perfect world, we would like to cover all services that people need. We don't live in a perfect world, and we have limited resources, and so we actually have to make choices, as I mentioned. We do this primarily by defining a benefit package. And so basically, governments are tasked to identify what services should be provided in a given context, and this is informed by burden of disease, their priorities, as well as a set of guiding ethical principles. It's important to notice that any priority setting exercise or any exercise to define a benefit package should be done through a deliberative dialogue. So the services can't be decided in isolation. They have to be done through community engagement, transparent decision-making, linked to what can in fact be delivered, as well as, of course, a budget assessment. Because what we see too often nowadays is that services are being identified, but then are actually not being provided simply because countries cannot pay for them, which is not a good thing, because this then leads to distrust into the health system by the population who actually tries to access services, but then actually have to pay for them out of pocket. So an example we also use very often of a country that has actually a very good decision-making process in terms of what services to include in a benefit package is Thailand. So in Thailand, the benefit package review process includes health professionals, academics, patient groups as well, and civil society, and it's that group that basically identifies priority interventions based on multiple arguments such as safety and effectiveness, but also burden of disease. Is it feasible to implement it? Does it provide financial protection, as well as several other ethical considerations? And these package of interventions are then subsequently submitted to HITAP, which is a health technology assessment agency, which is an autonomous body, who then looks at the cost effectiveness and the budget impact. But I need to stress again the importance of this deliberative process, because otherwise any priorities or the results of cost effectiveness that are being identified, if it's not done through such a process, will not be easily accepted and very often be disputed in front of court. So how does this apply to cancer, and what is the current guidance that can assist countries in defining priorities, and in particular those countries that do not have the capacity yet to conduct such a priority setting process? So we've heard from Princess Miret this morning about the WHO best buys. So the good news is that there are highly cost-effective cancer control interventions that are available. So the WHO recommends a series of best buys. These are basically high impact and cost-effective intervention, even in the poorest countries. And many of these interventions, here I'm listing primarily those related to cervical cancer, but many of these interventions will affect multiple non-communicable diseases simultaneously. And of course, the reduced consumption of tobacco is the most obvious example. But the current exercise on the best buys only covers 3 different cancers, which is breast, cervical, and colorectal cancer. So there was a lot of interest in trying to develop this further. And so this brings me to the practical side of my presentation, is that is the work that we've done, researchers at IARC in collaboration with our partners at WHO, and in particular my dear friend and colleague Andre Elbawi, who is here as well. So we have been working for the past 1.5 years, 2 years on developing a cancer costing and planning tool. And this is primarily to support countries in identifying this benefit package of interventions, to estimate the cost as well as the cost effectiveness, and also look at the budget impact. And I'm just going to present you very briefly, some guiding principles behind the tool, as well as how can the tool be applied and how it can actually be used to inform decision-making in low and middle-income countries. I have to say that the tool is still under development. We had a session, a very interesting one, I find, yesterday afternoon, but we're hoping to be able to have a fully functional version somewhere in the first half of 2020. So what does the tool do? And so this is very practical. So the tool enables us to estimate the cost and the cost effectiveness and budget impact for a wide range of cancer control interventions across the cancer continuum. So we're not only focusing on, for instance, early diagnosis only, we're really looking at the patient pathway through the entire continuum. We're doing this for 8 different adult cancers, as well as for 6 different childhood cancers. It's a tool that countries can actually use, so they can actually enter their own country-specific values, in particular related to the burden of disease, but also the prices for drugs, as well as medical technologies, and also look at their own health system capacity. We then generate basically a set of resource-stratified default packages of cancer control interventions. These packages can subsequently be customized by the user, and coverage and scale-up scenarios can be selected. So this then the final product is then basically a final proposed package of interventions. Relevant outputs include a health impact assessment, also the health system requirements, how much workforce do you need, how much equipment do you need, and what is also the cost of implementing population-based cancer registries. You can also look at the scale-up requirements over time, and eventually, and this is what we're also working on, is looking at the economic costs. We can look at disaggregation of costs for each of the intervention packages, but we will also be able to estimate at the country level an investment case for cancer prevention and control. So to show you very quickly, and these are my last couple of slides, a little bit what kind of outputs are being generated within the study. So we conducted a pilot study 2 months ago. So of course the first part is to provide a situational assessment. What is the burden of cancer? In the case of this country, it was 6,500 new cases and 4,500 cancer deaths. They had not many cancer control interventions, no national HPV vaccination program, for instance, and a little bit of cervical cancer screening. They had a very comprehensive national cancer control plan, but had not defined any priorities, did not cost the plan, nor did they look at the budget impact. Things that we also found out was that actually most patients within the country were diagnosed at a very late stage. Current health expenditure is relatively low, approximately 3% of GDP. And also we saw that the out-of-pocket expenditure was very high, nearly 60%. So on the basis of that, we costed their NCCP program, the total of 180 interventions, and found that it would cost a total of $2.9 million. Now, upon discussion with the Ministry of Health, it was immediately clear that they would never be able to pay for such a large amount. The cost of clinical services, which is not included in the programmatic cost, was anywhere between $500,000 and $10 million, depending on the complexity of the interventions that would be implemented. So on the basis of the tool, we actually redid the priority setting process, and together with them, we actually identified a set of priority interventions and reduced the program cost to approximately $728,000. Similarly, the cost of clinical services would be about $3.4 million, with actually medicine and health products taking up the bulk of the cost of clinical services, approximately 60%. And then subsequently, we could also see through the tool how much is required in terms of how many pathologists are required, how many medical oncologists are required, and so forth, as well as the requirements in terms of equipment and infrastructure scale up. Now, why do I mention, now, one of the advantages of the tool as well is that it also enables you to look at different scenarios. So for instance, we can estimate the cost savings that could be generated from doing early diagnosis, but we can also look at the cost savings that can be generated from different pricing policies or different tender processes. So for instance, in that particular country, we looked at what was currently paying for their cancer drugs, and then compared that to the global reference prices. And the difference we found for many of the cancer drugs was actually quite staggering. So we found markups of 4,500%, in excess of 4,500% for some of the cancer drugs. So this was a truly amazing finding, and it was also what the Ministry of Health agreed, that they could not understand that they were paying so much for certain of the cancer drugs. So through the tool, we were then able to estimate what the potential annual saving would be if they were able to actually source the drugs at a lower cost, and the saving would be approximately $500,000. Now, $500,000 does not seem much, but if you know that the entire NCCP program costed $700,000, actually those cost savings could then be used to fund other parts of their cancer control program. So that was just to give you a little bit of an overview of the tool, as well as the potential application of it. And so then I come basically to my last slide with a couple of key messages. And these basically voice a lot of the things that have been said since yesterday. So the first message I have is that government commitment to cancer care action and integration into universal health coverage is of crucial importance, and we know that all, of course. But effective cancer control will require multi-sectoral action, bringing a wide range of partners to the table, and also bringing the Ministry of Finance to the table, and therefore showing value for money solutions and return on investment are powerful arguments to argue for more resources for cancer and health in general. Now, in addition to that, we should also prioritize important programs and policies. Many of them have been shown to be very cost-effective for cancer control, in particular prevention, some early detection, interventions, and both of these have the potential to reduce healthcare expenditure. But we should also look, overall, we should also look at more critically at pricing approaches for technologies, and should not forget, of course, to build a workforce. We should ensure financial protection, as we've seen today, and in general, and that was also one of the interventions we had in the previous panel, we need to take a health systems approach, whereby making sure that the necessary facilities and human resources are at the heart of planning. My final key message I have is that we should not forget data systems either. In data systems, I understand both making sure that there are population-based cancer registries available in each country. These are not only important to identify priorities, but also to be able to monitor progress over time. But we also need to think critically within the context of universal health coverage, is that how can we actually track progress in implementation of cancer control interventions over time. Thank you.
Thank you very much, Filip.